With our Capstone project, we want to focus on improving the awareness and identification of mild traumatic brain injury, or mTBI. Specifically, an mTBI is a common injury experienced by female victims of intimate partner violence, or IPV. IPV can result in physical symptoms, cognitive impairments, and behavioral changes. However, the symptoms may go unrecognized and untreated. The statistics on this issue are grim. For example, approximately 1 in 3 women in the U.S. are victims of IPV. Of these victims, injuries causing mild traumatic brain injury are common, including blows to the face, neck, or head, or falls due to an assault. Despite the prevalence of this problem, the topic is not widespread in the literature, possibly because women in abusive situations may try to conceal or downplay the effects of violence, which can be further exacerbated by the long-term effects of multiple mTBIs.
Another problem is that there is a lack of training for awareness of this issue within law enforcement, specifically police officers. A common thread mentioned in the law enforcement training literature is that training is complicated by the nature of law enforcement work and law enforcement officers' schedules. There is a need for convenient and openly available training resources to assist and support law enforcement officers and other first responders in identifying possible mTBI cases in women in domestic violence incidents. One might expect, over time, that officers would pick up information and gain skills in awareness of signs of mTBIs. However, once the officer makes a decision to arrest or refer an individual, the officer may never receive feedback regarding the eventual diagnosis or any indication about the outcome of the case once it is out of their hands. Therefore, they face a barrier in learning to recognize the signs and patterns of behavior in such cases.
The reasoning behind conducting our Capstone project is that mTBI currently gets a lot of press with sports and concussions. For example, you may have heard about concussions, also known as mTBI, with football players, but female victims of IPV are an invisible, vulnerable population. Women who sustain an mTBI may be at risk for further abuse as they are not able to make decisions, problem solve, or get the help they need. If police officers can help identify the signs and symptoms of mTBI when responding to a domestic violence incident, they can help women get the proper medical treatment and help avoid the downward spiral into additional abuse, further impairments, and more vulnerability to violence. Finally, there is not much existing research on this topic, so we would like to contribute to this subject.
The first article we'll review is by Alice Davis from 2014, entitled Violence-Related Mild Traumatic Brain Injury in Women, Identifying a Triad of Post-Injury Disorders. The author conducted a review of available literature and included 40 research articles on this topic. The purpose of the study was to discover the relationship between mTBI and cognitive, emotional, and psychological disorders that may arise following IPV, including post-concussion syndrome, depression, and post-traumatic stress disorder. Following a mild traumatic brain injury, the woman may initially be confused, disoriented, not remember events before and or after the event, and may have experienced a brief loss of consciousness. These 3 disorders, post-concussion syndrome, depression, and post-traumatic stress disorder, may co-occur in this population, although it is unclear in what order these disorders may arise. Post-concussion syndrome, or PCS, may occur after a mild traumatic brain injury and last for weeks or months. Its major symptoms are headache, dizziness, fatigue, difficulty concentrating, irritability, anxiety, and noise and light sensitivity. It affects everything from activities of daily living to financial independence. The next disorder that can occur is major depressive disorder. Its signs and symptoms are not always visible, but its symptoms may include psychomotor changes, including agitation, fatigue, feelings of worthlessness, guilt, memory problems, concentration difficulties, indecisiveness, thoughts of death or suicide. Finally, post-traumatic stress disorder can occur following a traumatic event. Its symptoms include flashbacks, nightmares, detachment, irritability, anxiety, insomnia, agitation, headache, memory impairment, and dizziness. Many symptoms of these disorders that can occur after a mild traumatic brain injury overlap, including headache, agitation, restlessness, impaired concentration, irritability, and sleep problems. Repeated abuse puts the woman at additional risk. Specifically, chronic head injuries or repeated abuse may cause flashbacks, insomnia, depression, or other psychological problems including anger, irritability, hopelessness, and fear. Chronic repeated abuse, as well as the severity of intimate partner violence, predicted negative psychological outcomes in these situations. Some strengths of this study are the volume of research and review articles that were examined for the literature review. More than 200 articles were found, and 40 were included in the final review. Davis also used current articles from the years 2000 to 2012, in addition to older seminal works. Some weaknesses of this study are the level of evidence used. No Level 1 evidence or randomized clinical trials could be found to support the article. However, Level 2 research was found. This includes clinical studies without randomization or a multivalent case study analysis. Finally, the overall scarcity of the topic in the literature was another weakness.
The next article we will discuss is a study done by Joe Shackelford and Sarah Nail. In this study, law enforcement officers were trained on the topic of differentiating traumatic brain injury from alcohol intoxication. This was a pre-test, post-test design that used a non-randomized, criterion-based selection of participants, which were the police officers in the selected region, to do the training program. Their study was driven by the following research questions. Was the online training effective as evidenced by higher post-test scores? Was the training effective for each sign? And were more experienced law enforcement officers better at identifying TBI, as evidenced by those with more years of law enforcement experience showing higher pretest scores? 85 police officers in Kentucky took part in the training module in the summer and fall of 2013. Data from the officers were collected by Qualtrics, a research software. Descriptive statistics provided information for the study. The pretest consisted of two sections. The first section presented an interaction between a police officer and a suspect with a possible TBI, where the participant would indicate how many signs of TBI were present. The second session listed 19 signs that are associated with TBI and/or AI, and the participant had to indicate whether it was associated with either condition or both. A reliability analysis was conducted to support pretest reliability, and a comparison of the mean scores was conducted to evaluate the effectiveness of the training module. Paired samples t-tests were conducted to examine the effectiveness of training for the individual signs. The training module took approximately 30 minutes to complete and focused on informing the officers on how to handle an encounter with somebody with a TBI. Throughout the training, the officers were reminded and reassured that they are not expected to make a medical diagnosis for an individual, but sometimes need to respond quickly and always with a professional and respectful manner. De-escalation techniques and what appropriate questions should be asked were a large focus during the topic of handling an encounter. All of this content included a brief video recordings of someone with a mild to moderate TBI for authenticity. Severe TBIs were not discussed in this training due to the fact that individuals with severe TBIs are less likely to engage in activities and behaviors, like driving, that would bring them to the attention of officers. The content in the training module was drawn from current literature on the subject and presented the information topic by topic, beginning with an introduction to TBIs and how they affect physical state, communication, cognition, and behavior. The signs of TBIs were presented next, followed by indicators of a mild traumatic brain injury because they can present differently. Then, AI was introduced and the observable differences between the two and how they present when performing in sobriety tests. It concluded on how to handle an encounter with somebody who sustained a TBI. The results of officer demographics indicated that nearly all, 98%, of officers had received training in AI at higher or at some point in their career. However, only around a third of officers reported receiving TBI training at the time of hire, and more than half reported that they have never received training in TBI. The paired t-test results show that officers had significantly higher scores in the post-test in both sections. The officers found that years of experience was not a confounding factor in this study. So from these results, the training module was deemed successful in training differentiation between AI and TBI signs. Additionally, feedback comments from officers indicated an overall positive experience. The study had several strengths, most notably how it was highly accessible and convenient for the officers, being a brief training module that was done online. Its validity review was performed by a panel of experts representing both law enforcement and TBI. It also didn't necessarily focus on the symptoms of TBI, but the observable signs that one would notice. Additionally, the pre-test post-test design was a strength in measuring its effectiveness. Finally, a reliability analysis resulted in a Cronbach's coefficient alpha of 0.701, which indicates good reliability. The limitations of the study included its lack of a control group, small sample size, and the fact that the training was relatively brief compared to other trainings. In the comments section, an officer recommended that other intoxication causes should be included, or other conditions that might mimic TBI. There's a possibility that the officers perform better on the post-test due to the similar layout, which could pose a threat to internal validity. Finally, there was no evaluation on the maintenance of knowledge performed.
The last article that we will discuss is An Investigation into the Relationship Between Training Evaluation and the Transfer of Training by Alan M. Sachs and Lisa A. Burke. If training is considered to be a strategic human resource practice that can benefit individuals, teams, organizations, and society, then the evaluation of the training is just as important. What method can be used to evaluate a training program? Sachs and Burke discussed the utilization of the Kirkpatrick model of training evaluation. Using the Kirkpatrick model, training can be evaluated at 4 levels. Level 1 is reactions criteria, and it evaluates training's effective and attitudinal reactions to a training program. Level 2 is learning criteria, which evaluates the extent to which trainees have learned the training material and acquired knowledge from a training program. Level 3 is behavior criteria, and it evaluates the extent to which trainees have applied the training on the job, that is transfer, in terms of their behavior and or performance following a training program. Level 4 is results criteria, which evaluates the extent to which the training program has improved department or organizational level outcomes, such as sales or profits. The purpose of the Sachs and Burke study was to examine the importance of each level in the Kirkpatrick model while highlighting that the last 2 levels, behavior and results criteria, are better related to higher rates of transfer of training. The study included 150 participants that were members of a training and development association. Surveys were sent to the participants, and they were told that the purpose of the survey was to better understand training activities and to improve our understanding of training effectiveness. At the conclusion of this study, they found that among Kirkpatrick's 4 training evaluation criteria, only behavior and results criteria were related to transfer of training. As Sachs and Burke later state, it is necessary to measure the extent to which employees are using what they learn in training on the job. In order to successfully complete this task, evaluation of the transfer of training, the organization must focus on the behavior and results criteria. The strength of this study was its use of controls for the age and size of the organizations that were included. They considered that older and larger firms may have a more sophisticated and established human resources system. This would lead to a higher rate of training transfer as opposed to a smaller and relatively newer organization. A limitation of this study is its use of self-report data. While taking note that the usage of self-report data is a common practice in training transfer literature, it can result in method bias and measurement error. The rates among the 4 evaluation criteria may have been inflated. In addition, since it was self-reported, the measure of training transfer was based on the individual participant's judgment, and that can be subjective. Another limitation of this study is the use of 1 respondent from each participating organization. Even though knowledgeable participants were used in this study, training professionals with a significant amount of time spent in their position, there's still the possibility of measurement error. A researcher should evaluate a training program because after training has been offered to employees, organizations want to know if the training benefits justify the financial investments made and if the knowledge and skills acquired in a training course are indeed used at work. Training evaluation is therefore a critical part of the overall training sequence, as it will identify whether or not the training was effective and worthwhile. When using their Kirkpatrick model of training evaluation, level 3 and 4 can arguably be the most important levels when it comes to measuring training program success. Although level 1 and 2 are able to show the impact that the training had on the individual, organizations are interested in the transfer of the training program knowledge to the work environment, which is the information that level 3 and 4 provide. After the training program for this project has been developed and administered, the next logical step would be to evaluate the program in order to establish its effectiveness. Information in regard to the participants' feelings about the training and their learning outcome is important and can be determined by the evaluation of Kirkpatrick's levels 1 and 2. However, this project also seeks information in regards to whether or not the participants are using their learning in their everyday job performance and if the training benefited the organization overall. This is information that can be determined by the evaluation of Kirkpatrick's levels 3 and 4.
For our Capstone project, our first step would be to design and implement a pilot training program about observable signs of mTBIs in female victims of IPV. Our next step would be to conduct a pre-test and post-test to survey participants' knowledge of mTBI signs. Finally, we would evaluate the effectiveness of the pilot training program. Implications for future research would be to implement this training program with local police departments.